Welcome to the Back in Action podcast, where you're going to hear from me, a spine physician, Dr. John Lavelle, and two coaches, Dusty Holden and Josh Bunch. We're going to help you rethink pain, rebuild strength, and regain function so you can get back to enjoying the things you love in life without limits.
Welcome to Back in Action. Josh here with Dr. John Lavelle and Coach Dusty Holden. Gentlemen, welcome back to the podcast. Thanks for being here.
Absolutely.
Lots of stuff to talk about today. We're going to dive into MRIs, imaging, what we need to think, what we're told to think, what society says. And Doctor, I wanted to start with you. Right. First, can you walk us through what the difference is, MRI, CT scan, X-ray, and just give us a little bit of knowledge on that.
Yeah, for sure. So typically, patients want to see something within their back, because if you have external injuries, you're going to be able to see it, a cut. You can kind of perceive that if you have some kind of external imagery. But when it comes to the spine, you can talk all you want, but sometimes imaging, rarely does it give you the diagnosis, but I use it more for education to kind of show the patient what's going on in there, what it looks like. And it's really a good education tool. So like you mentioned, three of the typical ones we use: X-ray, MRI, CT scan. So X-ray kind of gives us just a basic idea of what the spine itself looks like. You're really just looking at when it comes to the spine, the bony elements. You can see some shadow of muscle and gives you an idea, but it shows us what the alignment looks like in the spine. And that use ionizing radiation. So X-ray has radiation involved with it to show you what the density of the bones look like, how that bone's alignment, joints look, and things like that. So that gives you a little basic information. Next is CT scan, which is also ionizing radiation, but it's just more high powered. It's multiple X-rays pretty much. So it's a lot stronger image, and then they compile it together to give you a more 3D image of what the spine looks like. And with that, you can see more of the discs, you can see some of the nerves and the soft tissue as well. Okay. But it's still primarily used in my setting for kind of bony pathology. Now, It can be used acutely for brain bleeds, tumors, things like that. But for our conversation, you're just getting a more detailed picture. If there's you've had spinal surgery, what the screws look like going into the bone and things like that. So those two are both radiation imaging based. And then you have MRI, which use more magnet technology. And that kind of helps. It looks at the hydrogen atoms in the body and then can repopulate an image using that to give you a much more detailed image of what looks like inside your body. So that you get a great view of what the discs, the nerves, ligaments, muscles all look like, as well as bone as well. So you get a much greater detail. So that's commonly when we want more advanced imaging of the spine to see what's causing, your spine pain. If we have to go further than an X-ray or just traditional exam, we'll get the MRI. One, I like it because there is no radiation, and there is some studies that show a slight increased risk of possible cancer or tumors with a lot of radiation over time. So I like to limit even X-rays, but if we're going to go to something more advanced, I usually go to the MRI, which is that magnet technology. So it does take a little longer to get the MRI. You're in a big tube, so people can get a little claustrophobic if they have tendencies towards that. But that gives you a great detail of everything going on in there.
It sounds like that MRI is better than just a broad scope.
For sure. I mean, it's for what I do in the spine, it's like the top of the line.
But generally speaking, it sounds like it also does what the other two perform, a CT scan and an X-ray. So why wouldn't we just use MRI all the time?
Well, if you're looking for specific bony fractures, or like I said, if someone's had prior surgery, the metal can cause a blurred image, so you can't see as clearly. So sometimes the CT is the way to go if they have hardware in there to get a better view of things. And a lot of people don't like the CT because you don't get as good an image of the disc. But if you've read a lot of these, like radiologists or myself reading them every day, you can still get a very good idea what's going on. But yes, I would say MRI is more the gold standard to get a better idea of what the pathology looks like in there.
You mentioned reading versus just having it performed. How long does it take to be able to read something like that? Because you always hear, and I know everybody's seen it, it's like, I got my MRI and it's going to be X amount of time before it's read.
Yeah.
What does that mean, and how long does it take to be able to read it?
Not to cause controversy, but that's just more buying time.
Okay.
So
doesn't take that long.
You get the MRI now, I can read it now.
Yeah.
If I want some patients, I do it acutely, rarely, because insurance is usually involved. But if I just wanted to put myself in my own MRI machine at work, I could then walk out and read it. There's no lag time.
How long does an MRI take?
Depends on the body part. And if you're just doing the lumbar spine, 20, 25 minutes. So you're in that tube. That's where it can get. I mean, you're in there pretty tight. Now, we do make bigger tubes, and they have open MRIs, standing MRIs. Just the quality is not as good.
You typically narrow it down like to lumbar, or would you take a whole look?
You usually don't need to look at everything, because if someone comes in with a low back pain, insurance narrows it down though. So they'll only usually cover one body part. Now, if you're seeing them for multiple body parts, like this, I've done people with cervical, thoracic, and lumbar. But if they're not having pain there, there's no need to do it, and we'll get into why there's no need to do it. Because the MRI imaging in general, I would say MRI gives you maybe 10% added information than what I already know from history and exam. So it doesn't give you the answer. It just, like I said in the beginning, it helps me educate. And it, obviously, if there's red flags, there's severe issues going on, an MRI is going to help guide surgery and things like that. But
it's
for
a piece
the
of the
day-to-day
puzzle.
piece, exactly. It's not the answer, which frustrates patients a
Well,
lot.
I think that's typically what people view it as.
100%.
I mean, I commonly hear that I need to get an MRI.
Yeah, and I'm gonna know what's going on.
Yeah, so they can get that
The answer.
the
Well,
final-
we want in society an answer to that problem, and we want it quick. But unfortunately, when it comes to a lot of injuries, you have a heart attack, you can get an MRI or a scan of your heart, and you're going to see deficits there, and that's the cause of it. So it gives you it. Where the spine it's just more of a gray area for better or worse, where you're going to see changes on that MRI in the spine on almost everyone. Especially as we get older, it's guaranteed. 30s and 40s, you're going to see some changes there, but usually they're asymptomatic or not even what's causing the problem.
Yeah.
So that's where it gets tough.
So if I go to you first time I've ever been there and I'm like, ouch, something hurts, your first step is not MRI.
Absolutely not.
Okay, so when is there a red flag to get me to an MRI? When do you make that be like, oh,
so if it's the first visit, you've had a history of prostate cancer, and now you're having severe back pain. You had treatment for the prostate cancer 5 years ago, but you're having some maybe urinary symptoms, but the pain's really bad. So I want to make sure that cancer, maybe it didn't all clear up with the initial surgery or radiation or chemotherapy, and now there's been some cells that have spread to the bone, so you get metastasis to the bone, and now you get a tumor in the bone causing your persistent pain. Or you're having constant fevers, chills, night sweats. Maybe you have an infection or something going on. Or maybe you get dialysis and you get a lot of IV treatment, and you're having just some weird symptoms. Like I said, maybe fevers. You're losing weight. I want to make sure there's no infection in the bone.
The symptomology is different. The symptomology of what you just described is not, oh, my back hurts. It's also maybe my back hurts.
Oftentimes they're coming in with a back, so that's where you got to get the history. What else is going on?
But there could be like a bladder, there could be an infection, there could be a fever, and there's other stuff usually.
Or do you have neurological deficits? Are you coming in and all of a sudden you can't lift up your foot acutely? You fell and now you can't raise your foot, or you're in an accident, you can't lift up your foot, so you're having some neurological motor dysfunction. Is something damaged, a nerve root damage that's causing that? So we get an MRI more quickly.
Gotcha.
So really that history has given me what I think is the diagnosis. So then I use the MRI to confirm it.
Okay.
But on a majority of patients, 90% plus patients, they're coming in with back pain. I have a good idea what it was. We're going to try a more conservative treatment first before jumping to that MRI, because usually it's unnecessary. So save that healthcare cost. There's not always a need to get the MRI. Usually I'm going to know what's going on anyway, and we can treat it, whether it's an anti-inflammatory, body's going to heal itself over a couple weeks, or get you moving with some exercise treatment, some stretching, and treat other things. Because that's what the cause of the pain is. The MRI is not going to change anything.
So go to you day one, you kind of have an idea of what's going on. You know kind of where the MRI may point to, have a general idea of that. So after the fact, I've got my results. Now there is something mechanistic. So in previous podcasts we've talked about, there's nothing mechanistic going on. That's another battle on coming back from something where there's no mechanical definition.
Right.
You're fine. What happens if I'm not fine? What happens if when you get the MRI, there's something there? And I know you said, there's always something there.
Yeah,
but let's say
sure.
you did see something that points in a direction.
Right. So let's say someone comes in with back pain right at their belt line. It's been going on for a little while now. They've maybe tried some therapy or done a little bit on their own, and it's persisting. So I get that MRI, and I'm already usually thinking maybe there's some significant arthritic change there, or some narrowing in the spinal canal, causing stenosis.
Okay.
All that can cause pain across the back. So then that kind of leads me to that. And again, it's that education piece where I can show, well, yeah, you're having back pain. This is what I thought was causing it, or maybe I didn't, but this is now that pain generator. Now we know what's causing it from this MRI. So now maybe we have to do an injection in those joints, or in that canal, a steroid injection, or if it's really not persisting, or you're getting more severe, what we call neurogenic claudication, pain going down the legs with typically walking, maybe you need to have surgery. So that's when those changes can help change treatment. So that's what the MRI can really do. If we're doing something that's not working, let's get an MRI and make sure we're on the right path, or do we have to switch gears because it's actually something else?
Okay. What if it's something like we've talked about before, like, whatever percentage at whatever age, if you're 40, 60% of the people have a bulge, or whatever the statistic is. But if you're that person where it's probably going to be strength and conditioning might be the issue, what is the ramification of you telling them their diagnosis? I feel like today that diagnosis is what everybody wants, but I also feel like, and Dusty, maybe you can back me up on this, what you see is that people then become the diagnosis, and then does that keep the pain state?
Then it gets back into the last episode with fear.
Yeah.
So now patients want the MRI because they want that diagnosis. They want that title. And back pain's not a diagnosis, that's a symptom. So usually we can tell them, if you take the time to talk to patients, their diagnosis without the MRI. Because you can know through history and exam and what they do, what they can't do, and what's been effective, what their diagnosis is. However, there's sometimes it persists, and where I like to get the MRI is for that education component. So let's say they've been having that same back pain and they have a disc bulge there, but they have no pain with flexion. They can do a deadlift, they can hinge at the waist, they can squat, doesn't reproduce any pain. The only thing that does is when they lean back or twist, because they're compressing those joints. So they have the disc bulge there. That's still not the diagnosis. That's wear and tear. That's tread on the tires that's been going on in your car for a while that caused that disc bulge.
So let me stop you right there, and I don't want to interrupt, but you're saying that I took the MRI for A, but I'm seeing B, and I'm going to tell you B isn't what's hurting you.
Correct.
It's this thing.
And that's where, if you just hand a patient a piece of paper, or the doctor does, and say, oh, you got a disc bulge at L3-4, L4-5, L5-S1, it's causing some narrowing around the nerves, or use crazy terms like you have a disc rupture at L4-5 that's causing some, mild stenosis, go see Dr. Lavelle or a spine physician. Well, then they think that's the diagnosis and the problem. And then you got to work backwards, like, yeah, that's there, but that doesn't fit your symptoms or any of your story. And then that's where the education piece comes in. We're explaining, yes, you have this. Why do you have that? It's, age-related changes per se, or like I said, maybe you did have some kind of trauma 15 years ago that may have caused that bulge, and that's not the cause now. But a lot of the things we see in that MRI, just as you mentioned, happen as we get older.
Yeah. I would imagine, though, that you pointing out, hey, there's this thing over here, but this isn't the thing, really conceptually changes that. Like, I could have a thing and I might not even feel it. It's
trying to diffuse that fear or that stigmatism of that diagnosis.
Yeah.
So I'm not just reading a paper with them. Usually I don't even look at the radiology report until I leave the room, because I don't want to be skewed in my opinion of what's going on. I want to look at the MRI with the patient. Sometimes it's the first time I'm looking at it too with them. So we look at it in detail together. I think we talked off air about this, is we'll do podcasts like that where we kind of go through an MRI and kind of explain what we're talking about here. I think that'll be helpful, because it's helpful for patients when I'm actually looking at the MRI they are and showing them, yeah, this disc bulge here, but that would cause, this symptom or that, but yours is here. And maybe I can also show, and see here, there's a little, swelling in, or what we call a fusion in your joint. So a little fluid buildup, or you have some arthritis here, and that fits when I lean you back. I'm compressing those joints where that arthritis is. So that's causing your pain. And that gets into how do we treat that? Well, we strengthen those paraspinals. And usually, the most common finding I would say I see on MRI is muscle atrophy and those posterior muscles that help stabilize that spine. So if we stabilize those muscles, I use the analogy like cables holding up a telephone pole. If those cables are strong, so those muscles are strong holding up the spine, they're doing the work. Where if you have atrophy in those muscles, they're much thinner. One, they're going to tighten up, so your back will feel stiff because they have to work harder. But two, you don't have as much cables holding up that spine, so gravity and all the things you do are pressing on the spinal elements themselves, and they can become more symptomatic.
We've talked about that before, and I find that infinitely interesting that you actually look for a much muscular atrophy within the MRI, and you could make the presumption that, hey, strength training to counteract that
Well,
could be
it
huge.
helps with the conversation, because if they see that, whoa, I do have some muscle atrophy to that, and that you relate it to them with an analogy that makes sense, the telephone pole or whatever it is, they kind of get it. And so then they have a diagnosis where my muscles are weak.
Mm-hmm.
I have some arthritis. That makes sense with what you're telling me. I do feel weak. It's hard to get out of a chair. And so it really helps them realize, oh, I do got to get moving more. And so, but then they're encouraged because they have a diagnosis, they have a treatment plan. They just weren't shown a paper, told you have this disc rupture, and you got to live with it.
Explained it. What causes muscle atrophy?
Disuse. So if you're sitting on a couch all day, you're going to get muscle atrophy.
Yeah.
And it's going to happen to all of us. I mean, if you're not training, you're going to lose muscle mass.
Well, and after the age of 40,
you lose 1%
muscle
of muscle
degeneration
mass a year is
Yes.
the average.
Yeah.
So the good thing is with muscles, we can fight against time.
Say that again.
Which one?
After the age, yeah.
After age 40, you lose 1% of your muscle mass per year. But you don't have to if you're training and strength training. It's just like, why do 40-year-old athletes, or later, LeBron James, why is he still playing and one of the best in basketball still?
Tom Brady.
Well, obviously.
You can name those guys.
Yeah. Why they still play? Because they keep training. And if we treat ourselves like athletes, if you want to keep going to your kids' sporting events and climb up the bleachers or lift up your grandkids, treat yourself like an athlete and keep practicing those lifts or those stairs going up and down or a squat off the toilet, so you can keep doing it till you're 100.
Have you ever seen it go the wrong way? And what I mean by that is you had the person who was feeling indiscriminate back pain, like they were ouch, but they weren't catastrophic, and then all of a sudden there was a diagnostic. Now, I'm not going to have you speak about other medical professionals. I don't think that's right, but it sounds like you're very rare in the educational aspect of it. But still, has there ever been that mindset of that person that has went in there, they've heard the diagnostic, and then they are just worse right after the diagnosis?
Like when they come in and hear the report and then they get that in their head and they feel 100%. And usually that's patients I'm seeing. They're coming in and they're worse off because they were given this diagnosis and told what their MRI looked like based on a report on a piece of paper. So is that kind of what you're referring to?
100%.
Then you got to that's where that education, you got to walk back all that. And so
in a perfect world, how would that if you could change everything to how you wanted it to be, how would that diagnostic procedure work to give them the best chance of success?
Well, that's a hard one, because you're going to see your primary care physician, and they can't know how to read every MRI out there, whether it's the brain, shoulder, heart, whatever it is, back. So
would it be starting
it's
in a different spot instead of primary care?
Well, yeah, but there's also not enough specialists out there to see all these people right away. So I think just listen to this podcast.
That's it. That's
and
the
then
key.
you'll have the information to give your patients.
You got it. That's
easy.
the key.
No, but just not scaring your patients. So knowing that the spine, because you have changes, doesn't mean doom and gloom. You can have changes on your MRI, and that doesn't define necessarily what's going on or you, and oftentimes those aren't even the cause of your pain.
I think it's just important to
Does that kind of make sense?
Yeah, 100%.
Go back to the fear aspect, because we know what fear does.
Yeah.
And it's paralyzing, So I think when you're talking to the patient, it's just really important that you're talking them through what they're seeing, and you can pick up on that. When somebody is like going down that path of it's very, very fear driven.
For sure.
And I think that's where it starts to get slippery. When there's fear and then there's elimination, like you start eliminating certain things in conjunction with the fear that you're feeding it. And that's where it kind of manifests itself into this really, really big problem.
And it's scary too. So like you said, where should we start? It's finding that person, that physician in your community that can educate you appropriately. And that's hard to find, but there's people like me everywhere. So someone that'll take the time to listen to your story, show you your imaging, and explain things that's going on. Or if you haven't had imaging, just listen to you and putting their hands on you and actually diagnosing you what's going on to get that good process moving forward instead of someone that's just rushing you in and out of the door. And it's
unfortunately, that's not to speak bad about an individual. That's more for how the system
both.
is set
It's
up.
individuals and the process.
Why do you think it's so like fear-based?
Medicine in general?
Yeah.
Well, I don't know that it's intended to be fear-based, but physicians don't know the power of their words. So physicians, you come in, I don't wear a white coat, I sit down next to them, but many come in with a white coat. You know, you're sitting there, nowadays you're just typing the computer, barely listening. So they're already fearful because of the situation. There's a white coat syndrome. So you're fearful walking in the door, what am I going to hear? And when it comes to your spine, everyone's fearful about that because no one wants to be paralyzed.
Yeah.
You know, they want to be able to move again and do the things they want. So they're already scared coming in the door. So then if you tell them they're just all negative information, we've gone on about that in the past, that's just propagating that. So it's not always intentional to instill that fear, but also if you're not providing compassion when you're educating them, people are fearful. They're scared. They don't know what's going on. And then if you don't educate them, then they have that fear coming in and they've been told negative news, they're going out even more fearful.
Dusty, you said something really smart about taking stuff out. Like, we really make sure we never have to amputate movement.
Yes.
Once you take running out, it might never come back. Once you take jumping out, it might never come back. And to do that to an athlete, we would never take that lightly. We might do it temporarily, but that leads to what would be the protocol. So we've already seen the doctor. The doctor says, yes, the MRI confirms this or X or whatever it may be. Is there a standard protocol that you would use when somebody comes into you? So Dr. Leva has prescribed strength and conditioning, whatever that may be. Is there a protocol to move forward if they do have something on the images?
Well, yeah. I mean, depending on what he said, typically he gives us kind of a snapshot of what the patient's, dealing with. Really, it's to attack it. It's to go right for it. So if it's like we need to strengthen those spinal erector muscles, I mean, we're going right after it. We're not trying to work around it.
Yeah.
I think the first order of business is let's attack what is the weakest point, not get there over time. So it's just really one of those things that we want to. I mean, our main goal is to get somebody back to regular life. It's like doing all the things, whatever that is. So if you're in a position where you're not bending over, you're not working, you're not doing certain things, well, I take all those things and I just kind of like prioritize them and create a plan of like, I'm going to get you back to all those things.
So first step in the protocol, when I come to you and I'm like, this thing hurts, and Dr. Level's already seen it and he's told you kind of what's going on, you're going to sit down with me and say, what is it that you want to be able to do, maybe that you're not doing currently?
Yes.
And then you build the program around that. So it's not a template that's applied across the board. It's so if I want to be a marathon runner,
yeah,
we're going to go
let's
back
get
to
you
that.
there.
Okay. And if I want to be a strongman,
yep,
we're going to go to that. And those will be two completely different protocols.
Oh yeah.
Okay.
And same thing for you're a grandma and you just want to get back to playing in the backyard with the kids. It's like let's start moving in that direction.
Yeah.
And it looks different for everybody. There's no one shoe that fits everybody. It's more of a very individual based, and again, like I think the big difference maker is what kind of it's different with you is we listen. We take the time to just hear what somebody's going through, hear some of the challenges that they're facing, and let them just get it all out, empty all the baggage, so to speak, or unpack it. I mean, I think that's like the biggest takeaway from what you're talking about on the MRIs. Let's just unpack this thing. Let me talk you through it. Let's not speculate or guess or any of those things, but I want to hear exactly what's going on. And then I'm going to walk you, in a direction that's going to get you back to what it is that you want to do or wherever it is that you want to go.
Well, and it's like you just said, we're attacking it. It's not a passive approach. I don't take a passive approach in the office. I'm going to aggressively kind of listen to them, examine them, and this doesn't take hours on end. I don't spend that much time with patients. I wish I could spend more. But if you show that compassion and that you care and listen, just to their story for the first couple minutes, they're intrigued because that's new to them, unfortunately.
And I think that too, like your natural default, if your back is hurting, is you stop doing the things that involve your back. Or if your shoulder's hurting, you stop doing things that could aggravate your shoulder. And I think that can work to a certain degree, but when
sounds right to the ear.
And I'm talking days,
yes.
Not weeks, not months, not years.
Right.
And so that's where it's tricky that people understand that, because that's another question that, we ask is like, how long has it been? How long have you been resting?
Go ahead.
Go ahead.
I was just going to say, it's not just fear of patients. I think physicians get fearful when they don't know what's going on too. So the default is, well, don't do anything yet until we can get you to someone that can really talk to you about it. For example, I just sent Dusty a 15-year-old kid, 300-pound football player, 6'5", and just listening to his story. Well, this happened in March. He had a hit, gets a stress fracture in his back. So since then, he's been doing very little. He's gone to therapy for for the first month. He was told to do nothing because, quote unquote, bone will heal in 4 to 6 weeks. So do nothing then, and then do some physical therapy. But they're still nervous because he's had a fracture of the back. So everyone's scared. Mom and dad are scared. He's scared. He's never going to play football. The people treating him have been scared because they don't want to hurt his back further because he's got a fracture in the back. And so everyone's been scared along that way. So if you listen to the kid, he said, well, I was 5'8" in January and now I'm 6'5". He had a growth spurt. So all that stress through the muscles and those bones predisposed him to having that stress fracture. So knowing he's growing, his bones are super healthy, showing him the MRI, your MRI it looks good, you're fine. And then the parents kept asking, well, we were told it was a complete fracture. I was like, you just have a stress fracture in the back. Mechanistically, this is how it works with an extension type injury. You can get a pars interarticularis stress fracture. You've waited plenty of time. Let's attack this now. And that's what he'll be back playing football the end of July.
Big difference between passive care and active care.
It's just,
man, how do you go from 5'8" to 6'5"? Why didn't I get any of that?
No doubt.
I want every piece of that.
I may have just exaggerated, but it was within the last few months. He's been 5'8" or 5'9", and now he's 6'5".
What's interesting about him too,
that's when you grow.
Yeah,
and when hormones change, and we're getting off topic here, but adolescents, you get these big growth spurts with kids.
I'm 5'8" and I stayed 5'8", so
yeah, you're done.
What's interesting about this athlete is this athlete just came in this morning and through his evaluation has no pain.
Yeah.
So he's not in pain now, but because of all this, the path that he's kind of walked down, he's in this just hold pattern, and he's been there for months, and we're not talking about a 60-year-old, person who doesn't have like a lot of, say, physical demand on their body. We're talking about a high school football player, and but just because of the information that he's been told, he's just doing nothing.
Yeah.
And even if I had seen that kid initially in March, let's say the injury happened on a Friday night game. Well, it's March, so football's not on. But let's say it happened on a Friday night, and I see him a week or two later. He's already rested for 2 weeks. Yeah. So we're already there's no need not to keep him conditioned and move him. We're not going to go anything crazy on the low back. We're going to give it some time for that bone to heal, but we're still conditioning him. But he's going to be back playing in 2-3 months. But now it's been since March, and we're in July.
Yeah.
So there's no need for it to have taken this long. We just got to take a more active approach.
So if I was coaching another coach and they were let's say they were a good run coach, I'd say that's great, and then they were going to want to get into teaching snatches or Olympic lifts, I would say that would be negligent if you didn't have some sort of a background in that. Yeah. So don't. Now, I say that just to say, is there a time where they could have went to a practitioner that would say, I don't really know, so don't? Is that correct in that aspect, or should they immediately tag somebody else in? Like, what's the protocol? Yeah, like if they're really more, I'm not really sure. Is it more negligent to have prescribed something?
I mean, usually that initial contact would be a primary care doctor. Okay. So yes, it should be, I'm going to send you to a specialist who can really treat you. For me, if someone came to me and I think, you're deconditioned, your back hurts, but you're short of breath, you're getting chest pain just on exam, I'm going to send them to a cardiologist. So what would I say? I would say, well, you can stay active. Nothing bad's going to happen. Don't overdo it, and we'll get you into a cardiologist quick. But I'm also going to take an active approach there and make that referral to a cardiologist and make sure and follow up with that. I'm just not going to say, you got to go back to your primary care physician, get a cardiologist.
3 months later,
exactly.
Something happens.
So same when someone's referring to me, I give out people my cell phone all the time to practitioners and say, just text me if you have a patient that needs to get in quick.
Gotcha.
Let's move this. There's always such delays along the way, and it doesn't have to be. It can be quicker. I mean, yes, we could always use more physicians, but there's still ways, if you care about the patient, that we can move the process along quicker.
Why do you think there's a lot of reluctancy to like tag somebody else in?
Well, ego comes in the way for sure. And then it's a little insecurity. You don't want to be seen as having done something wrong or not knowledgeable about this. But I think, that we need more communication within healthcare providers. That's how you can get people better. You need a team. It's not one person.
Well, that's what that's how we operate. And we don't over communicate, but we get enough information to be able to do what we do. There's a working kind of flow to it where we are a team. It's like we want to get this patient of yours in as quickly as possible and get them moving in a positive direction as soon as possible. And I think that, again, it builds so much more trust and buy-in from people when they feel like there's this it's a working relationship. Yeah, like we're all in this together rather than you're kind of out on an island by yourself, and this is the only way to do something.
For sure.
Dr. Laveau mentioned red flags in terms of like what would be a red flag to get to the state of an image.
Yeah.
So by the time, again, in this particular iteration, by the time they get to you, they have the image. What are the red flags that somebody may say to you, maybe specific words that really like sound stuff off to you, that it's going to be more about how they view what they do for recovery than necessarily what you might prescribe as an exercise? Are they giving themselves a narrative that's keeping them down?
Well,
are there specific words that if I was a listener, I need to watch out or try to listen to myself and be like, whoa, wait a minute. I need to not say that, because that might make it worse.
Well, I think like when somebody wants to bring me the disc of their MRI in the first session, that's a huge.
Is that because their now their identity
well, it's
is
almost
wrapped
like
up
the
within their injury?
blueprint,
Okay.
And I'm a coach, trainer. I wouldn't have a clue.
Not what we do.
Looking at the MRI, like for me to see
that's
that.
an even better podcast. I'll read an MRI and you read an MRI and
tell you what I see.
That's right.
But again, that's where I put like my trust into him. That he's already taken care of that part of it.
So if they come in and they've already identified as their injury,
they're attached. They've attached themselves to it because it's almost like. And
they'll say that, I'm having pain right at my
like,
L3-4 disc. Well, you can't feel it. You don't know. You can't isolate in the spine what disc or level is causing the pain. It's just not, the nervous system doesn't work that way. You get more generalized pain or referred pain, so you got to induce it. But you can't say, oh yeah, I've been told 25 years ago I had a slip disc at L3-4, and that's what's going on again, I can tell. Now, some people are intuitive, but you can't actually feel what's going on. So that, to your point, is people hear these things and then they'll come in and say, well, it's this disc again.
So Dusty, in that iteration, maybe they're 3 months down the road, maybe they're 3 years down the road, never have done anything to actually recover or to strengthen. How do you break that cycle of, I brought you this thing, this is 3 years old, or what is your first thing to do to get them to get over that?
Well, again, I listen. Okay. I don't try to discredit it or to...
Because they really hurt.
Yeah, or to make them feel, weak or whatever, discourage them. Mm-hmm. That's the last thing you want to do, I think, at any point, but especially to somebody that's in pain because they're already... everything's heightened. So any type of discouragement, like you just really want to try to, steer away from that. Everything that we discuss or we do, you want it to have a positive outcome. So that's really, really important. And I think, once we start moving, it can be very, very low level movement that we're talking about. But that's all part of just kind of stacking and building those wins and encouragement, because every time we do those things, that's where the fear meter is lowering and this buy-in is building, and so until we can ultimately get them to the point of doing the things that we know they need to be doing that are going to actually move the needle for them. But in the beginning, it's all about us just building some rapport and trust, so that they will really just do what it is that you're asking them to do.
If I'm somebody that comes to you that has had a diagnostic, there's something coming back on an image, or let's just arbitrarily, the most common could be either a stenosis or a bulge of some sort, whatever the most common could be. Are there movements that the listeners do not want to do if they have that diagnosis and it's their first time back into the gym or into the gym at all?
Well, I would say, don't just jump back into the gym and start ripping heavy deadlifts off the floor and things like that.
Somebody who's never done that, are there movements that I need to avoid?
No.
So if I'm somebody that does have an MRI an image that shows something, there might not be movements that I have to avoid, even though.
For example, like someone comes in, I have a disc herniation. I've been told not to bend.
Yeah, that's impossible.
You get through the day.
Yeah, you can't function. So I think when you start, that's the tricky part about eliminating is you're changing like the way the human body is designed to function. So we may like really lower those movements down to where there's the sensitivity or their heightened awareness is lower. So I think I said this in one of the previous, it's like we're probably going to go to the ground in the beginning, just so we can kind of like relax a little bit. Let's shut down some of the fear of moving your body through space. And then we'll build from there. It could be that's where we spend all of our time the very first session or two. And then we're going to bring it up to the feet. I have had many, many patients over the years that have been, just really, really fearful and locked up when they came through the doors. And those are the ones where you really got to take people by the hand and get them into a position, and you can see through their face and their reaction, like
those are the ones I love to send them because I know it's going to drive them crazy.
Well, I'm joking, but the thing is, it's a really awesome opportunity.
Sure.
Because I think from a training standpoint, sometimes we overcomplicate it. We think we got to do this like the flashy, things with them, and it's really not. It's just about, I think, more restoring movement patterns than it is even introducing things that they maybe have never done before. So you don't even necessarily have to have done a deadlift for me to be able to teach you how to properly hinge at the hip.
Yeah. Doctor, when you hear of another professional saying something like, you never want to deadlift again, you never want to do X again, does that make you cringe? Do you think, okay, there is a time and a place for that, but is it ever really permanent like that?
Well, some people think it is, but yes, I cringe because
die inside.
Because it's, sometimes I just got to hold back my self-control because it's just a lack of understanding and knowledge and realizing what the human body's meant to do, what the human body can do, and just also following over years of where data has shown us that you can and cannot do. You mentioned a good thing, though, a couple minutes ago about you never discredit anyone. And I think that's the biggest thing when someone comes in and is just been told what's on their report or is really feeling I can't do this, I got this, or I've had this for 25 years. I may be thinking right away that no, that's not it. But I'll always discredit them. Say, well, let's take a look. Let's see what's going on here. I think that's a big point. Is as a specialist, you don't want to just think you have that power, and you're going to shut patients off. They're going to just go out less in a positive environment if you're putting them down versus just because they may say something silly or crazy or been told something crazy. You don't want to just discredit them or bash someone else. It's just explaining. That doesn't do any good, but just explaining the why and what is actually going on and why it's okay to do this or why you may have thought this, but no, this is the process.
Well, here's the thing too about that. I think everybody thinks they're the only person that's dealing with whatever
when you're
that
in pain,
is.
you are the only one in pain. That's for sure.
You think in your mind, like, I've got something going on with my back that is just, it's nobody's ever seen it before.
And that's how pain works.
Yeah. Yep. And so even though, like, you can hear it, we can hear it and go, we've heard this or seen this 1,000 times. I think it's still important that you treat it though as if
it's the very first time.
I've never this is an anomaly. Yeah. We really need to dive in. Yeah. But knowing that you hey, we're about to do this thing,
Yeah.
So I think that's what's powerful again. And people can pick up on that. They can see that you have the confidence.
That's true.
I can help you. And I'm not just telling you this. Give me some of your time, and I'll show you. How I can do that. So I think that part, the personal connection, to me,
it's the key.
It could even be more important than actually what you're physically doing with them. And that part takes time. It takes really a lot of talent too. You've got to be good at listening. Mm-hmm. I think one of the biggest things that I've ever learned over the years is if you listen long enough, they'll tell you the problem and give you the answer. Mm. And so again, we as professionals, we think sometimes we have to be the one that answers all the questions, but a lot of time it's just listen long enough, and you're going to find out everything you need to know.
Doctor, is the MRI permanent? So if you see the thing, is it always going to be the thing? And if it is, does it matter?
So when you have changes on your MRI, meaning the thing that's causing the pain?
Correct.
Okay, so no. So that's where we go back to the prior episodes where a lot of these things we see on the MRI are there because of how your nervous system is responding to it.
Okay.
So no, you could have a disc herniation. Now that disc herniation often is going to be there forever. It's not going to go away. When people say, oh, I can adjust you and we're going to move that disc back in, that just doesn't happen. Sometimes the body can come in and clean that up. But usually that disc bulge, disc herniation, or the arthritis there, it's just going to get worse with age. It's a one-way street. But you can get that nervous system by strengthening the muscles, which then gets you into the nervous system to desensitize it and just tone down that nervous system response. You're going to significantly minimize it. So you may still have those changes on the MRI, but you're no longer having pain. Okay. Just like most people have changes. Everyone, as we get older, has changes, but most people don't have persistent pain.
Okay. Dusty, same kind of thing. If you could give me a percentage of I come in and I'm in pain, is that pain going to be permanent? So when you see somebody that comes into you that's in pain, is that pain going to be permanent? Are they going to be feeling that a month from now, 2 months from now, strength training? And if not, or what is the percentage of athletes that come to you in pain and then not all of a sudden, but months past or years or however long that may be, they're out of pain?
Well, I think it's 100% that your pain will decrease.
Okay.
Now, will you be out of pain? That it's hard to tell. It's hard to know. But I think what we can assure them is your pain level is going to decrease, and we're going to teach you and show you how that you can still do all of the things that you desire to do. And it's going to be at least tolerable. It's going to be something
on functioning, not the pain. So
I think the important thing is, and I would tell you this is again, it's 100% of the time, people feel better when they move. Always, they come in. maybe the pain it's flared back up, or they just had like a little downturn or bump in the road.
Yep.
But once we get moving, they will always tell you, I feel better now. I always feel better when I leave, or than I did when I walked in. And so that again, it reaffirms the power of movement.
Yeah.
So it's amazing to me. Like, 7 years ago when you sent me your first patient, and just kind of like one by one taking these people.
And that first patient, by the way, I wrote his name and number on a sticky note, and I said, you know what? Let's try something outside of the box. We're gonna try this. And what was the story? I mean, she came in and she was like, this doctor just gave me a sticky note with her name. I just took a chance, and now look at where we are.
Well, and when she came in, she barely could get through the door. And when she set her purse on the floor, her she had a spasm, screamed in the gym. I mean, like literally terrified everybody there.
Okay.
And I took her by the hand and we went right to the floor and we started doing like just some soft tissue work. And then we kind of progressed that into a little bit of movement.
Yeah.
And that person is still with me today.
Unsurprising.
But it's when you take those people one by one and when you're walking with them on this journey and you see the impact that the training aspect of it has not only on them physically, but emotionally and mentally, I think that's where it again, like it's so important as the practitioner that you are literally giving these people life, and sometimes like their life back. So it's not something to be taken lightly. And I think that's where the power of the words and the things that we say to them, we need to be really mindful of it, because people they have a tendency to attach themselves to certain things. Well, why don't you have them attach to something positive that could have impactful meaning, on their life? I don't know of anyone, and the only people that haven't gotten better are the ones that just really they quit, they give up, and it happens. But I think it's just well,
and like you just mentioned with that, how they have pain, they may still have pain, but they're going to function better. It's that old rusty gate analogy. That gate's rusty and stiff, and it's just going to get worse with time, but it still functions. Same with us. We're going to get older. We're going to get rustier. Things are going to get stiffer. But if we keep moving that gate, if we keep getting up and moving, you're going to be able to keep doing it and enjoy the things you want in life.
Thank you for watching. Join us for much more where that came from. And when you get a chance, follow us on Instagram and YouTube at Back in Action Podcast.